Welcome. I'll take you through the details of those stories. Now, Ghana is nearing effective containment of COVID-19 as latest data supplied by the Ghana Health Service reveals significant reduction in active cases and new infections. In its latest update, the service says active cases have dropped below the 1,000 case mark to 856, the lowest in months. Head of our health desk, Fred Smith, reports.
The data reveals 4 new deaths, bringing the death toll to 280. But there is some good news about the country's battle with SARS-CoV-2. Positivity rate dropped from 65% at the start of August to 10% on September 1, signaling the country's strategy may be working. Only 55 positive cases were reported from the labs in the last update, one of the lowest recorded in many weeks. But it takes Ghana's case count to 44,713. Of this number, as many as 97.5% of patients have recovered. So far, 4 of the 16 regions are without any active case, whilst others are reporting single or double-digit figures. Only 3 regions, Greater Accra, Central and Ashanti, have active cases above 100. It may still not be time to rejoice yet, as further easing of the restrictions could trigger a second wave. The reopening of the country's international airports and the possible start of political rallies all point to risks requiring significant attention.
Risks requiring significant attention, as Fred puts it. Dr. John Amwese is a lecturer of the Global Health Department, School of Public Health, KNUST, and leader, Global Health and Infectious Disease Research Group. He's joining me right now so we can talk briefly about this. Doc, thank you so much. It's been a while. I trust you're well. I'm trusting that you can hear me. I can't hear you. I think your mute button.
Airport is open, or our borders are open.
Okay, I think you are muted. So if you can unmute for me, I just want to first of all find out what you make of the new or the latest figures we're getting from the Ghana Health Service.
We have no idea whether the airport there is open or not.
Okay, you. I don't know if you can hear me. Can you hear me, Doc? Hello?
Yes, I can hear you.
Okay, great.
I'll go ahead and answer your question if that's all right.
That's all right. Go ahead.
Great. No, so regarding the numbers we're seeing, you're perfectly right in stating that it's looking better than it was before. That's how I like to put it. I'll tell you the reason why. You made reference to positivity rate, and this is a good way of putting it. And what the positivity rate means is how many out of, or what proportion out of those that you're testing are positive, right? This is a little different from what we call the incidence rate. But whatever be the case, we can conclude fairly accurately that the rate of the infection seems to be going down, or the number of positives seems to be going down. What ideally we should be doing, which I've maintained over the past couple of months, is to be carrying out regular surveys, what we call sort of sentinel kind of surveys, to really measure the rate at which the infection is spreading, so that when the rate of decline, or if there's a decline in the spread, you can confidently say there's a decline in the rate of spread. What we are seeing now is a decline in the proportion of positives, and this is directly related to how much testing we are doing. You recall that we used to be doing a lot of contact tracing, testing a lot more samples, but now we're not doing all that contact tracing as much as we used to, as was announced by the Ghana Health Service, and we're also only testing people who come to the hospital and say they are sick. So this is not to say the positivity rate is false or not reliable, but I'm just pointing out that it may not necessarily reflect the rate of spread of the disease. Now, what's more important to me is perhaps the hospitalization rate and the death rate. And it's clear that we have less people admitted with COVID-19 in our facilities. This is undeniable because the beds are empty. We also have a lower death rate, all right? So with these two, the hospitalization rate and the death rate, I could say that things are looking better than they are before. I would not harp so much on the positivity rate as I would on the infection rate or the incidence rate, and then also the hospitalization rate and the death rate.
That makes perfect sense. But then we've also opened up our borders. And I did hear this argument, by the way. I have no way of verifying it, and I probably put it to you if you can, that there are different strains apparently of this virus, and that it has its own character that applies geographically. And so now that we've opened up our borders, especially we're allowing air travels, that we could actually be inviting different kinds of strain into our system.
No, I think that's a really great question, and certainly an important consideration. In recent communications and publications, it's clear that there are a couple of strains of the SARS-CoV-2. In fact, the most recent information on this is telling us about 6 different strains of the SARS-CoV-2. Well, I'm not a virologist myself, and really in a forum like this, it's not so important to go into the details of what strains mean. But all this means is that certain genetic material, which forms part of the virus, may be changing from place to place. This may or may not change how infectious disease is, may or may not change how much it causes severe disease. In fact, for the new strain that was detected in Southeast Asia, particularly Hong Kong, it's suggesting that the strain is causing less severe disease, but is not having any change in the way the disease spreads. We do not know as of yet exactly how things are going to pan out, but generally, all these SARS-CoV-2 strains seem to be highly optimized for affecting humans. I mean, it's like a specialized weapon against humanity, if I put it that way. Now, that being said, once we open up, it's very clear that we are likely to be inviting more strains, and that is if we are not able to quickly catch those who come in. And this is why it's so important that that net, which we use to sieve those who come in, be it via our air or land borders, is as tight as possible, so that to the barest minimum, we reduce people getting into the population without being first detected and treated and being free of the virus before being released into the population. I can only trust and hope that with what we see so far, with the 70+ booths of the Kodakat, I was going to say teaching hospital, but the Kodakat Airport, and doing the antigen testing, and then going ahead to do the PCR test for those who turn out to be positive for the antigen. I think that sounds like a pretty, tight arrangement, and we can only be hopeful that we will not miss anyone, and we'll keep ourselves free to a large extent from strains that may change our story, which is not looking bad at all right now.
Well, Doc, I say a very big thanks to you, and I probably leave it there. But the point that Fred raises in the report he put together was that there are things that we need to do. And you've rightly mentioned the 70 booths that we have at the airport. Do you, from your perspective, think that that's enough to do what we're supposed to do?
Well, what I can speak to is the kinds of testing that we're doing. You're doing an antigen-based test, and then what this means is that you're trying to detect the presence of what we call an antigen, which is present in the virus, which is a clear evidence of an active infection. And then for those who are positive for an antigen, you go ahead to do a PCR test, which I believe our colleagues in Noguchi and others here, hopefully at KCCR also will be doing. That arrangement is pretty standard. Nobody's doing anything better than that all over the world. But as to whether it's enough, it's really a function of the rate at which people are entering into the country, the numbers of flights that are coming in, and how much the amount of time they're going to spend at the airport. And this really is a calculation that can be made by anyone who is conversant with the numbers who come in. 70 sounds like a good number, but I'm really not in a position to say, as a matter of fact, that this is enough. It's also a function of how much time we intend for someone to spend right from when they arrive, you know, when the plane docks and then when they get off and then get out of the airport. So it's all a function of what we have estimated.
And finally, people have said that we should have been a bit selective with this intervention, that we should have been selective with the countries from which we admit people. Do you think that makes sense?
Well, as it is, it's very difficult to say one should be selective, because you have Ghanaian nationals who've been stuck abroad for quite a while. In fact, there's been more Ghanaians stuck in Africa than even in North America or Europe. And people transit through all kinds of places. I think once the net is not porous, it doesn't really change much by putting restrictions on which countries people are coming from. The focus should be on catching them quickly and early, treating them, making sure they don't get into the population and spread the disease.
And I certainly hope we do. Thank you so much for your time this afternoon. Dr. John Amoise is a lecturer at the KNUST, sharing his perspective on the new data released by the Ghana Health Service as far as our performance dealing with coronavirus. They say there is a significant drop. And he's been explaining further, saying that, well, there is a drop in hospitalization, there is a drop in the rate of infection, but the positivity rate is still something we can have a conversation about. So there's a positivity rate versus incident rate.